just going to briefly introduce Dr. Valerie Sabataro. He is going to be helping moderate the next two sessions. Dr. Valerie Sabataro is a nephrologist at University of Maryland. He has been in the PKD field for more than 15 years. He studies PKD in a research lab, and he sees lots of patients with PKD in clinic. Thank you.
Thank you, Rachel. Our next speaker is Diana Bruen. Diana is a registered dietitian and founder of the PKD Dietitian, where she specializes in helping people with polycystic kidney disease use nutrition as a proactive tool for their health. With over 17 years of experience in renal nutrition, her work focuses on translating the science of PKD into practical, doable dietary strategies. She is passionate about making nutrition a first-line approach, empowering patients with options beyond just waiting for dialysis or transplant. Without further ado, Diana, the floor is yours.
Hi, everybody. Thanks for having me today. I'm going to go ahead and get started. So today, I'm going to be talking about practical nutrition strategies for PKD, because we can have all the knowledge, but without actually taking action, it doesn't do us any good. So for today, I'm going to talk about what I call the pillars of PKD nutrition. I'm going to go over what are those pillars, why are they important specifically for your kidneys, but of course, how to start making positive dietary changes, good goals for you, steps to take, and some of my tried and true tips. So this is how I like to look at nutrition for PKD. I like to put it in three categories. Number one is the pillars of PKD nutrition. They will benefit everybody, and they really are that foundation of your good diet for your kidney health. The second area is areas where you might need to reduce, remove, or replace some of the stuff that you're eating. And then the third area is stuff that has perks for PKD. Because we don't want to just focus on what to take away. We also want to include what is doing good. And with that is a nice mental shift. So speaking of a mental shift, I want to step it back a second and look at how to think about PKD and cyst growth. So we all know PKD, the mutation, leads to kidney cysts. And those kidney cysts, it really comes from that gene mutation, the PKD1 or the PKD2 genes. Now, those genes and that mutation, they've got altered pathways, which is why things happen a little differently in your body and your kidneys. And those altered pathways are impacting the kidney cyst. But what else impacts them is kidney injury and stressors. So if we're looking at this very simplified path to what is impacting our kidneys and our cysts, we can't change our genes yet. I always put that in because I believe it's coming. So focus on those altered pathways and those areas we know will stress your kidneys out or injure your kidneys. So focusing on that and shifting to what you actually can control, that's a nice mental shift. And here's the thing, guys. Those altered pathways and those kidney injury and stressors, guess what? They have a nutritional component. And that is what I find so fascinating and powerful around nutrition for PKD. So here's just some of the general recommendations. Overall, a healthy diet and weight, of course. Many of you, I am sure, have heard, okay, don't eat too much protein, watch your salt, and, drink some good fluid. And with lower kidney function, so that lower GFR, some people might need to limit potassium and phosphorus. Well, that protein, salt, and fluid, Guys, those are your foundational pillars. Those are definitely the important pieces where someone who asks me, where do I start? It's right there. Now, I want to show you this image just to bring it all together. So we know what is connected with faster progression. All the studies in the end say, okay, we know this is connected with faster progression. So high blood pressure, more protein spilling into your urine, obesity or being weight, we know is connected to faster progression. Having kidney stones, especially more than one, diabetes, high uric acid levels, inflammation, having an acidic environment in your body, and dehydration. All of these are connected to faster progression. And guess what? Every single one of these has a nutritional component. And with some of the people I'm working with, I definitely like to reverse engineer so we can prevent some of this or help to fix it. So remember I was saying we got those 3 areas for nutrition opportunities, and I love that area. On the top here, really your foundational pillars, your protein, your hydration, and your sodium. And this is what we're going to focus on today. But those other 2 areas, the reduce, the stressors, the injury, and the workload, the reduce, remove, or replace, and then additional opportunities. And I just like showing this image as one because it shows you how many opportunities you have. Now, I want you to hear me when I say everything on this image is not relevant to you. You don't need to do all of the things all of the time. These are just some things we look at specific to each of you, if it would benefit you or if it's something that we need to work on to prevent complications. So here's what we're getting into. Those pillars of PKD nutrition, the sodium, the fluid and hydration, and the protein. And we're going to dive in a little bit so you guys really understand the why and the how. So let's start with sodium, your first pillar of PKD nutrition. And I'm using sodium salt interchangeably here. What exactly is sodium? It's actually an essential mineral, meaning you need to get some in your diet. So no sodium is not a good idea. Low sodium is much better. You need it for your nerve and your muscle function, and it absolutely helps to regulate your fluid balance in your body. Like I said, you need some, just not too much, because we know high sodium intake is absolutely associated with faster cyst growth, something we definitely don't want to do. So looking in your kidneys, specifically your PKD kidneys, here's why sodium's important. So we know that a diet high in sodium, you're going to have higher blood pressure. And you think about blood pressure in your heart, but there's pressure in your kidneys too. And I always think of cyst kind of like a balloon. And when there's more pressure, what happens when you blow up a balloon? It gets bigger. So it's absolutely connected with increased cyst growth. And with that, larger kidneys. But did you know that a diet high in sodium, you're increasing your risk for kidney stones? And more protein spilling in your urine, which we don't want that. More protein is associated with faster progressing PKD. So where does the sodium come from in your diet? There's natural salt and stuff, like celery has some salt in it, eggs have some salt in it. And then the big component is it's an additive. So why is sodium added to our foods? Number one, people like the flavor. It kicks it up a notch. And it's also a preservative. It is the oldest preservative in the book. So if you're looking at some packaged foods and it says no preservatives and you flip it over and it's got a boatload of sodium, that's a little bit of false advertising. But what's important to know is 80% of the sodium that we consume, both you and me, is added to our food before it even reaches the table. So it's in the food at the grocery store, it's in the food before it's delivered to your table. That is where most of our sodium is coming from. And I like this visual. I'm a big fan of visuals. So as I mentioned, almost 80% of our sodium is already in our food before we get it. So anything that's processed or packaged or restaurant or we drive through is going to have quite a bit of sodium. And that is where, if you're working to reduce your sodium, you should focus. Now, this 5%, that's the salt shaker on the table. Not much. This 6% is in home cooking. And then this 12% is natural. So as you can see, the biggest impact about what we're consuming right there, processed, packaged, and restaurant food. So that lets us kind of focus on that if we're working to reduce our sodium. Anybody want to guess what the average sodium intake is in a meal? Not just fast food, but even in a restaurant meal. And I'll let you think about it for a second before I let you know the average intake. For over 1,400 milligrams of sodium. So one meal out, we've already put a huge dent in our sodium goals. So as you can see, it's another way to look at most of our sodium's coming from that processed food or even before it gets to us. I want to give you guys some numbers for those of you who like numbers. What are your sodium goals? You'll see it in different areas. So usually you'll see less than 2,300 milligrams a day. I always like to say, let's aim for less than 2,000 milligrams a day. Just so you know how much this is, 1 teaspoon. So if you have that 1 teaspoon, that is about 2,300 milligrams a day. So you can visualize how much that is. So when we break this down, we got the one whole day. What does that look like per meal? So a good goal is less than 600 milligrams of sodium a meal. And you can even do that when you're looking at frozen foods or restaurant foods, because a lot of them are listing their sodiums these days. And per snack, it's about 200 to 250. So that's a nice way to look at it if you want to break it down to per snack and per meal. And if you're someone who cooks at home, first of all, kudos to you. But when you are cooking, of course, the first thing we want to do is look at the grocery store, what we're bringing at home, but I'll touch on that in a second. But when you're cooking, you can see, I like this visual because it shows you 1 tablespoon of sodium. That is a lot. So it shows you, and generally, I've done a lot of recipes, but generally I find you're safe with adding about 1/4 teaspoon when you're cooking, because this is, say you have 4 servings, this is going to be divided between the 4. So you can start thinking about, if I have a recipe, and of course, usually they're adding a lot more sodium, you can say, you know what, I'm going to cut it back to this. But it adds up quickly. So here are some of my sodium tips. The number 1 tip is, as much as you can change from packaged to fresh, that is the easiest tip, because remember, that sodium is in our packaged. So if it's fresh, all the stuff that doesn't really even have a label, it does not worry if it naturally has some sodium in it. That's the number 1 tip. Even if you're eating 2 meals out a day, even changing 1 will absolutely reduce your intake. And my second tip is just to check in with, okay, how much am I actually consuming? You might be surprised. You can do a salt tracker. There's a ton you can print out online. You can just write it down. And I like the Chronometer app. You can download it for free and just do a check-in. Like, how much am I actually consuming? And for those of you who this is your goal, to reduce your salt intake, know this: you have a salt appetite. The more that you have, or the more that you have in your meals, the more you're going to want. So the less sodium, you're going to adapt to it. Your taste buds are going to adapt. Now, I'm going to be honest here, it's going to take a minute for you to get used to that. And it might taste a little bland at first, but in 1 to 2 weeks, you will 100% be adapted to that less sodium. So here are some steps for you guys to take action. Of course, number 1, as much as you can move from packaged and prepared to fresh. That is how you're going to make a big dent out of your sodium intake and hit your goals. Number two, like I said, know your numbers. How much am I consuming? And start there. So if you're consuming 2,600 milligrams, what's a good goal for you? A good goal might be to bring it down to 2,300. It doesn't have to be drastic. You can continue to make goals along the way. Where do you start looking at stuff? Scour your pantry. Look at your broths, look at your canned food, look at anything there. And you can see, well, starting out with what I'm cooking with and what I'm getting from the grocery store, it'll take a little work on the front end, but you will You will soon know what your favorite products are. So look at the grocery store, look at your pantry, and also check the label. So in general, our label is going to give us per milligrams, and it's going to give us a percentage. 5% or less is low sodium. 20% or more is high sodium. So to look at a label, here we go. The sodium right there, 7%, that's not bad. So you want to look at per serving, because if something's low sodium, but we eat 5 servings of it, we're definitely getting a little more there. So this is 160 milligrams and about 7%, not bad. So give yourself grace. It does not have to be exact. So 10% or less, that's pretty good per serving. Better is less than 10%. Best is 5%. So you have a little flexibility here. And this is per item, not per meal. So if this was a snack item, this is definitely a good choice because it's below that 200 to 250. And if it's part of a meal, it's definitely a good choice too, because it's not packing in the sodium. So I want to back it out to a meal. Like I said, per meal, around 500 to 600. And then per snack, 200 to 250. So this salad here, it's got some Kalamata olives on it. It's got a little bit of feta. And immediately I know what all of you guys are thinking. Oh, that is high in sodium. But we're thinking not per item, we're thinking per meal here. So if we're looking at those olives, 4 to 5 olives, that's less than 200 milligrams. And the feta, 2 tablespoons, which is a fair amount. This picture probably has more. That's about 200 milligrams. So for a meal, maybe we're throwing on some grilled chicken, we've made a homemade dressing and kicked up the veggies. It is still per meal in your sodium goals. So sometimes when you're doing a meal, you need to back up and think about, okay, what is the whole sodium package here? Okay, we're going to get to our second pillar of PKD nutrition, and that is fluid and hydration. What is a good goal for hydration? So water. We are made up of over 60% water in our body. All of our cells need it, not just your kidneys. All of our cells, all of our organs, it helps us to regulate temperature. It keeps our joints lubricated. It helps us get rid of waste when you sweat, when you go to the bathroom. It helps our digestion. It prevents constipation. It helps us deliver nutrients to our cells. I'm sure you're picking up on that. It's super important. So here's what is good hydration for PKD? This is actually good hydration for everybody, of course, unless they have a fluid restriction. So aim for about 3 liters of fluid a day. That's about 100 ounces. Water is 100% your best option. And with PKD, you want to hydrate throughout the day. So there's no moments where you're leaning towards dehydration. And guys, absolutely okay to slow down before bed because everybody wants a good night's sleep and not to have to get up and go to the bathroom. So I'm going to geek out a little bit. Don't worry, we're not going to get too sciencey here. I want to talk about your kidneys and hydration. So there's this hormone called vasopressin. I like to call it the dehydration hormone. So when you are starting to become dehydrated, or your body needs fluid. It sends out this hormone that says, hey, hold on to fluid. And it's talking to your kidneys. And when that hormone, it comes right here and lands on this receptor, so it docks right on this starts a whole bunch of stuff in the kidneys that brings fluid and moves fluid, among other things. Guys, with PKD, you have more vasopressin floating around, more of this dehydration hormone. And unfortunately, it is connected to faster cyst growth. It is a driver of cyst growth. So what we don't want to do is add more. So with your good hydration, what the goal is to prevent this dehydration hormone from making more, sending more out. And know this, before you even feel thirsty, your body will have sent this message out because it needs to hold on to that fluid. So that is why it is good to have good hydration habits to not make more of this. And on a side note, guys, any of you who are taking tolvaptan or Genarcu, that medication comes and lands on this dock, this receptor, and it blocks the vasopressin from landing. So that's how that works. It prevents a bunch of it from having that downstream, basically fluid surge in your kidneys. Like I said, the goal is to prevent more vasopressin from being released. We know that higher water intake, and the studies are mixed, guys, that it is associated with slower cyst growth and smaller kidney size, both good things. But outside of PKD, just CKD, slower progression of any kidney damage, decreased risk for kidney stones, and it's good for your kidneys and whole body. And remember, it comes down to that hormone, but it has so many other benefits. So what are your hydration goals? Ask your doctor if you're worried that you might have a restriction, but in general, aim for about 3 liters a day. That's about 100 ounces. You can see it measured out. Water is your best option. Folks that I'm working with, I always say, let's make a plan for water. Everything else that's fluid is bonus. Drink it throughout the day. And as you notice, good hydration, we're right back to the same image, is your hydration goals. And slow down before you go to bed. Water being your best option and having that as your goal, the food that you eat is bonus fluid. And I love to think of, okay, I hit my water goal, I space it throughout the day. Everything else is bonus fluid doing good to you too. So I just show you a couple of images of stuff that has a fair amount of fluid in it, and cucumbers have a ton. All of this is bonus for you. So here's some hydration steps. Number 1, how much are you actually drinking? Measure your water bottle, look at how much your favorite cup is, get your baseline and see, oh, I'm doing pretty good. Or, you know what? I'd like to increase that. So set a good goal. Now, you're not going to want to increase it from 2 to 3 liters in one day. That might not be comfortable. So give yourself the grace to start slowly. And intentionally add, I found about 8 ounces a good 8 ounces is a nice number. And another tip, easy access equals success, guys. So, and this might sound like the simplest thing, but if you're working at a desk, take your water bottle and put it on the side opposite your mouse, because it will be available to your free hand, the hand that's not doing your mouse. And believe me, you will drink a lot more fluid. But also, I know a lot of people that have the water bottle for the car or one in their room. Make it easy. When you see it, you're going to want to drink it. And even, in fact, I bet a bunch of you, while I'm talking about fluid, picked up your water bottle and drank some right now. That's the wonderful power of suggestion. Last but not least is your third pillar of PKD nutrition. And guys, this is protein. Protein, just like salt, is an essential nutrient, meaning that you got to get some in your diet. Your body can't make it. Protein is super important in your body. We build muscles with it. We repair our tissues. It's important for you to fight infection. But know that protein in excess, having a ton of it, doesn't make any of this work better. So you need some, just not a ton of it. What's important to know is that dietary protein and the intake is responsible for a major part of your kidney's workload and waste. And that's why it's always important to touch on. High intake of protein, and guys, I'm thinking keto or carnivore or just any of those super heavy intakes of protein, it is stressful to your kidneys. In our digestion of protein, we're increasing the waste our kidneys need to filter, and we're increasing their workload. It absolutely creates an acidic environment in your body that your kidneys need to try to balance. And high protein intake, it can impact how much is spilling in your urine. And none of these are good things. So this is what happens inside your kidneys, specifically PKD kidneys. The key is balance. Meet your needs. That does not mean you need to be vegan or vegetarian. It does not mean that you need to give up meat. It just means, hey, I might need to check in with, am I having a ton of protein at the cost of other things that are good for PKD? I like this visual because there's no one size fits all. We have general recommendations, but your needs based on your diagnosis, your labs tell a story, your kidney function, your body composition. Do you work out a lot? Are you super muscular? Exercise, your age? And all of these are like, well, you probably need more protein or you need less. So absolutely, if this is something that confuses you, talk with your doctor, work with your dietitian. They can tailor this to you, but not only that, but show you what it looks like. So here are some very general recommendations for PKD. And if you have your phone on you, I'm going to show you how to do some calculations if you're a number person, so feel free to pull it out. So 0.1 to 1 grams of kilogram of your body weight per day. This is a general recommendation. Do not go over 1.3. That is a high amount of protein. And like I said, we're taking into consideration, how much do you weigh? What's your kidney function? Do you have other things going on? What do your labs show? And then, of course, your personal and nutrition status, your personal goals and your nutritional status. So when it comes to protein, if you want to get a general number, and this is not differentiating between animal or plant, here's how we do it. So take your weight, whatever you weigh. So I gave this example. This is 150 pounds, and divide it by 2.2. So 150 pounds, whatever you weigh, divided by 2.2. So that comes out to 68 kilograms. And we see protein recommendations in kilograms. So then you take your weight, this 68 kilograms, and you can multiply it by the 0.8 to 1. And that'll give you a nice range and an idea if you want to check in with, okay, well, what's my intake like and how am I doing? Here's some protein tips. The type matters, absolutely. Meat is going to have a lot more protein, so it is harder to stay within a normal. And as you can see here, this example, 3 ounces of chicken, put it in range, is about 26 grams of protein. And then half a cup of chickpeas is about 6 grams. So you can see how much does different per type. And so if you are finding that you are doing heavy meat or protein intake, my tip is pick more plants, pivot towards more plants. And a nice cheat is about 1 ounce of meat is 7 grams of protein. A really easy way for you to check in with how much is this. And avoid collagen supplements. And I put this on here because collagen is hot commodity in the wellness world right now. Guys, collagen is just a protein supplement, and it's not something you really want to add on in excess. I like this visual. It's how I like to view PKD and protein, because you can have all of the sources of protein. It's all about balance, and pick more from the plants. And I do like to differentiate between meat and the stuff that comes from meat. So you've got, your egg, your yogurt, all the other things, and then we've got poultry, and then red meat at the top. So more from down here, less from up here, but everything is possible for you. Now, here are your protein steps. Think about, guys, and you can write this down if you want to, and I'm only talking about animal meat here, because in the big picture, this is the one that's going to push you over the limit that is good for you and your kidneys. So look, and it also makes it easy. How many meals, think about how many meals each day do I have with meat, specifically meat? Okay, so maybe you have 2, lunch and dinner. Okay, so how many meals does that equal a week? Wow, that's 14 meals a week I have with meat. So that's a fair amount, guys. So start thinking about, okay, that's my normal intake. Well, how do I want to change that up? And do I want to change that up? And maybe it is, I'm going to go down to 10 meals. Maybe it's, I'm going to have 1 a day. A lot of people I work with will do 1 meal a day with animal meat. I tell you, it usually ends up being dinner, but it's a really nice way to ensure we're not going wild and crazy. And mix it up. Try out some different proteins and pivot towards those plants. You do not have to give up your meat. You do not have to dramatically change all of this, but figuring out how much is good for me, how much am I actually eating, and what small steps and shifts can I take? Now that we've touched on the 3 pillars of good nutrition for PKD, those foundational pillars, once you have a good rhythm with those, that's when reduce or remove comes in. And that's really stressors, injury, and workload. And I just wanted to highlight these again. These are some areas that PKDers work on or are impacting them. But again, you do not need to do all of the things at all the time. It's more specific to you. And then options and opportunities. These are the ones with perks for PKD, and these are not for everybody, folks. They are just opportunities, and it should be individualized to what will benefit you with you. So if you remember anything today, it is diet 100% can impact your PKD health and your progression. Start with your pillars. Once you have those, a good focus and on lock, and you know the rhythm, everything else is so much easier. So check in with your sodium, your hydration, and your protein. And then maybe work on taking away some of those kidney stressors, but don't do it all at once. And explore your options and opportunities to do positive for you, your kidneys, and your whole person. All right. I hope you guys found that very helpful and enlightening and took some good steps away from it today. I'm going to go ahead and stop sharing my screen.
So first question from the chat. Some people have PKD and hypermobility, such as hypermobile Ehlers-Danlos syndrome. The hallmark is lax connective tissue, which also affects blood vessels, POTS, postural orthostatic hypertension, orthostatic tachycardia syndrome is very common. The recommendation for treating your POTS symptoms is consuming lots of salt and water. That is completely opposite to the advice you get when you have PKD. Keep sodium low. How does one balance this in a safe way?
With POTS, you are correct. It's generally recommended for a high sodium intake so you don't have that low blood pressure. What I recommend is working with your doctor and working with your dietitian to find the right balance for you, because coming into play is both your diet It's coming into your medication if you are on stuff also. So it's finding the right balance for you. I do find that sometimes we do increase the sodium intake, and it really is individualized for POTS with PKD.
Potassium is listed on food labels and phosphorus not always. What is the best way to find phosphorus levels in food? Do you have suggestions on target potassium and phosphorus levels?
So for phosphorus, it really depends on what your function is. It is something that your kidneys filter. If you have great kidney function and you are rocking and rolling, first of all, amazing. But what I say to stay away from is the fake phosphorus. So that is the phosphorus that's an additive. So you do not need to worry about phosphorus that's in your meat or your nuts or stuff like that. Stay away from the fake phosphorus. And it's not on the food label. There's a lot of push to get it on the label. Most people do not need to know about it. So who knows if it'll ever be there, but look in the ingredients. So they add it as an additive. It will be PHOS, and the lower it is on the ingredients, the less it has. Now, if you see it on a baked good, it might be part of the baking soda. So in general, it's the processed food that have the added fake phos. If you are someone who has low kidney function and are on a phosphorus restriction, that is usually between 800 and 1,000 milligrams a day. But talk to your dietitian, talk to your doctor. They can work with you on how to do that in your diet. But in general, I say avoid the added fake phos.
Hi, thank you very much for the presentation. Quick question. So I understand red meat is worse than white meat, but what's the difference between 10 grams of protein from chicken breast versus 10 grams of eggs or tofu? Like which one is better or worse? So that's my question.
Good question. And without getting into the nitty gritty, protein is made up of chains of something called amino acids. And different types of protein have longer or shorter chains, and they have different amino acids. Where it comes down to it is those details. So red meat is going to have different amino acids that have more waste, they create more work, they produce more toxins. And so that will differentiate the different meats. And when it comes to, I always think of them kind of like a big Lego, and you're putting the different amino acids together and how your body responds to it, what's created when it's digested. And that really is the nitty gritty. So the red meat has much more of that. And we have a pretty good research history of looking at red meat's impact on the kidneys. So that's a big difference between red meat and then also poultry. And then also thinking about what the perks for PKD are with, I think I had a picture of salmon up there. You're getting the omegas, and then you're getting other things that are beneficial too. And it is different. So the meats being categorized like that, but when we're looking at the like the yogurt and we're looking at the eggs, they have different amino acid breakdowns too, but they also have perks for PKD in them. So they don't cause as much of that waste, and they don't cause as much of that work. But in addition, you're getting calcium and other components too. In fact, with dairy, I love a lot of the studies that break it out and actually say it's beneficial, like very, very different. And I hope that answers your question without getting too complicated.
We're going to take another in-person question, and then we'll do an online, and then back to another in-person.
Hi, Diana. Thank you very much for this presentation. I got really excited on some of these slides, a lot of things that were resonating. My name's Greg. I am a patient that started on tolvaptan recently, and so I am doing great on that fluid pillar. I am just doing too great, actually, is why I'm asking.
Yeah, right?
I am thinking I'm drinking about like 6 liters of water some days, and I'm starting to worry, is that too much water? Should I be putting in some electrolytes to balance how much water I am? But then we run into salt again. And should I be on there's even low sodium, no sodium electrolyte mixes, but is that cheating sodium because there's like not NaCl, but a different type of salt that might be hiding in there. But just wanted to ask you, without reducing my water, because I'll slow down a little bit, but I got to keep drinking that water. Is there a way? Should I be concerned? Should I look to electrolytes? I'm exercising a lot. Is Gatorade bad for me because it's got too much salt? Any comments you have on that topic?
No, great question. And electrolytes are definitely all over the place right now. So the risk, that's awesome that you're drinking that much fluid. Tolvaptan does increase that thirst. The risk is that basically your electrolytes are going to be too diluted. So look at your labs. How you can tell is look at your sodium level in your labs. That will tell you how diluted you are. It doesn't speak to, it does not speak to how much sodium you take in. And talk to your doctor, like, does this look okay? So when it comes to electrolytes, you want to eat them before you drink them. So you got your sodium is electrolyte, potassium, magnesium, even calcium. It just carries a little charge in your body. You absolutely can do an electrolyte replacement if you are out, like in the heat and sweating and everything like that. I would go for one that is low sodium. Some of my folks I've worked with who are actually professional athletes, and we do, like they're doing long distance stuff, we do add in some sodium. Those are absolutely fine. What I would not make a habit of is doing it every day just because. There's usually potassium in them. So if you are on a restriction, but in general, more potassium is better. I think someone asked me that earlier. The potassium goals. So yes, you can check out how much sugar, because a lot of them are sugar bombs. Check out how much sodium, and it is an option for you. Some of the powders do have that added fake fuss. So there's a little bit of looking around and figuring it out. If it is something that you want to add to your everyday.
So time we will take 2 more questions, one from chat and one from audience. So next question in the chat is regarding slowing down hydration before bedtime. I know nephrologists have specific concern about the hydration deficit at night, and guidance is given to actually drink more before bed and even in the middle of the night. This seems to be counter to the guidance of slowing down before bed. So just want to be sure I understand.
Right. Always listen to your nephrologist and talk with them about it. I have found that with folks I'm working with, that a good night's sleep impacts their health dramatically, I think, for everybody. And so we do slow down. And if they do get up in the night, sometimes they do drink. But I'm talking about people that were getting up 5 and 6 times. So it is different. I've heard that recommended too, but I generally recommend slowing down, that you can still hydrate, you can still drink, but you don't have to have your, big gallon jug and hydrating. It is finding the best balance for you, because sleep's important and other aspects are important too. Because sleep actually does impact your kidney health. Everything does.
Okay, last question from the audience.
Hi, I'm a nephrologist specializing in PKD, and I'm also very interested in nutrition. And one thing I just want to mention is the stress about the added sugars. I'm very interested in just talking to patients about what they're eating. And a lot of patients, we talk about the salt and we talk about all the stuff that you talked about. I've given talks, similarly. And the last few years, I've really thought more about the carbs. A lot of patients, the bagels, They're drinking the Cokes, and I feel like it's not addressed enough. And I just want to stress the importance. There's so much research now into limiting carbs. I know keto is still controversial, but even just lowering carbs. We talked about obesity is a problem, diabetes is a problem, inflammation is a problem. And so there's really this push now. It's really interesting about this low carbs. It can help with all those things. And again, it's not so simple and we need more research, but I just always want to stress it because a lot of patients, when I dig in and they're, again, the Coca-Cola, the desserts and things they don't even realize, the breads and things. And I think it's important. I just want to mention that just for patients who are here and listening, that it's just really important to talk about that too.
Absolutely, I agree. And I think the big thing there is to differentiate and to make it simple, good carbs and bad carbs. Vegetables, natural carbs, yogurt, natural carbs. So those are not a problem. Your sweet potato, natural carbs, your whole grains, natural carbs. So those are not a problem. The only reason, because they are good for you, they compact in fiber and nutrients and all these things. Those are not bad carbs. We do not want to villainify them. Yes, we do, if someone is doing ketogenic therapy, which 100% needs to be done with your healthcare provider and an expert, not on your own, guys. If someone is doing that, the only reason those vegetables and fruits and all that is reduced is not because they're bad, but because we're reducing total carbs. And to compare those good carbs to what you're talking about is the added sugars and the really, really processed stuff, very different. So to do a check-in with, healthy carbs versus unhealthy carbs, that's a whole different ballgame. But yes, very important. Added sugar, and I think it's important to highlight that, which thank you for doing.
Thank you very much, Diana. There are 3 more questions in the chat. If you could please answer them in the chat. So,
Sure.
okay, thank you.
Thanks,
Thank
everybody.
you so much.
Our next speaker is Dr. Ashima Gulati. Dr. Gulati is a pediatric nephrologist with research interest in inherited kidney diseases, with a particular focus on polycystic kidney disease. Dr. Gulati trained at the Yale School of Medicine, where she also completed a PhD in investigative medicine. Her research focuses on human exosome-based investigation of kidney disease and diseases and using preclinical disease model for investigating disease mechanisms in autosomal recessive polycystic kidney disease. Dr. Gulati's clinical interests include the integration of genetic knowledge to improve the well-being of children and with polycystic and inherited kidney diseases. Please welcome Dr. Gulati.
Thank you for the kind introduction and almost good afternoon. I'm excited to be here because this is the last but not the least important talk, and we'll talk about children with PKD. I think as a PKD-focused pediatric nephrologist, when I sit in the clinic and most of my clinic population is, almost all of my clinic population are children who have some kind of a cyst in the kidney. And when you have a cyst in the kidney, you get referred to my clinic. And the number one diagnosis that I see in that population is ADPKD. And nothing to disclose. So and the number one diagnosis is ADPKD, not because we don't have other causes of cystic kidney diseases in children, but because ADPKD is the most common. And talking specifically about polycystic kidney disease, and this is a well-informed audience, there are 2 types, the autosomal dominant and the autosomal recessive. And the dominant is much more common. We know that. And today's talk will be focused. We'll talk about autosomal dominant polycystic kidney disease, but I'm happy to take any questions about ARPKD as well. So why do we need to just talk about these 2 as very distinct forms, although there've been studies are there interlinking mechanisms, pathomechanisms or pathophysiology, but just on the clinical face of it, these are very these are two different distinct forms of PKD. ADPKD having a totally different gene defect, totally different proteins involved. ARPKD having a different gene called PKHD1 and a different, similarly sounding but very different protein fibrocystin. So just by the gene and the protein defect and how these two diseases mostly present, they are very different. So it's important to recognize that these as two separate entities. And talking mostly about like the pediatric issues in autosomal dominant polycystic kidney disease, I think it's important to touch briefly upon what's the diagnosis, how does the diagnosis look like in children? Because we know that kidney failure or advanced kidney disease does not manifest in children with ADPKD. What's the significance of blood pressure control, and how should a follow-up assessment in children look like with ADPKD? There is less clarity on if all children with ADPKD or all children at risk for ADPKD, should they even see a pediatric nephrologist, and what are those, what is that gray zone, and what does that look like, and what should be done? And then are there other complications or other things that we can address in this population? I think we are fortunate that we have some more tangible and very clear guidelines now, specifically focused on ADPKD, with an entire chapter dedicated to children with ADPKD. And the KDOKI, the Quality Initiative in the US, has a commentary on the KDIGO guidelines, the internationally accepted guidelines, and talking about some of the specifics of how different things can be managed in children with PKD, ADPKD. So I think these are very good resources. Talking specifically about the diagnosis, why do we worry about, when we're talking about ADPKD, we still want to touch upon ARPKD, and that's because there could possibly be a phenotypic overlap in certain situations. And though, as I said, like it's very different presentation-wise, different genes, different proteins, but when you are looking at a small infant or a child with ADPKD, you always, as a pediatric nephrologist, need to question yourself and say, is this ADPKD for sure? And that is because a very small proportion of ADPKD will present very early in life. And this is not just like finding by screening ultrasound. This is clinically apparent or clinically presenting ADPKD with some kind of a severe presentation. And ARPKD, as we know, mostly presents as a more severe presentation in the fetal life or as an infant. And so there can be some overlap. And so even when I'm doing prenatal consults with the fetus having bilateral kidney cysts, ADPKD is always one of the differentials in addition to ARPKD. And then on the corollary, there will be a very small proportion of ARPKD individuals who have very mild disease and may be confused as having some other kind of polycystic kidney disease. So there is definitely a possibility of overlap. The diagnosis of ADPKD in children, I think it can be divided into two categories. One is, the typical asymptomatic form, which is the most common form that we see. And this is when children are at risk. We know that they are at risk because of the family history, and then we tend to find out because we wanted to find out, or they come to the ER or have another medical intervention or interaction for some other reason, and incidentally you find out that they have bilateral kidney cysts, and that's the typical, and that was not the problem that they presented with. So the typical asymptomatic form is the most common form. But then, as we said, there is a very small, about 2% of all ADPKD can present as a very early or early onset symptomatic or severe cystic kidney disease. And that is something that will come to clinical attention much early. And so that is a very distinct entity that, a pediatric nephrologist would see. And that's an entity which obviously cannot be missed and needs to be accurately diagnosed, not to be confused with ARPKD, because management implications are very different in early onset, say a neonate presenting with ADPKD versus ARPKD. So there are very separate management implications. So that's something that needs to be recognized. And in such situations, genetic testing is particularly useful, especially in early presenting PKD or if there is an absence of family history. So what about making the diagnosis by choice? Children who are at risk for ADPKD, but due to a family history, and whether all those kids should be screened, and when to screen and how to screen. And I will tell you that this has been a kind of a gray or a controversial or a less consensus area traditionally. I think we have some more guidance from the 2025 guidelines, but all in all, I think there is a heavy share of responsibility both on the providers and the families to make that joint decision of screening, and the providers' responsibilities to present all the knowledge and to talk about what the screening modalities are. I think it's been traditionally a gray zone and continues to be, a kind of a little bit gray zone, because currently we don't have any validated stratification models to identify children who are at risk for rapid progression in ADPKD. And there are no approved therapies for children with ADPKD, because if that was the case, then we would be finding out for sure. And the other, things to consider are that ultrasound, which is our to-go modality for finding about kidney cysts, the first modality to see if you have kidney cyst or not in a child. If you have a negative imaging in a child, that does not definitively exclude ADPKD, because kids can develop cysts over time. And so the utility of having one negative ultrasound imaging may not be the answer. Genetic testing specifically for ADPKD genes can be definitive, but again, how the genetic results are interpreted and what we find when we do genetic testing for PKD1 and PKD2, we can only say a 100% certainty, or that, is this positive, is this result negative, when the familial variant is known. If the familial variant is not known, there can be a situation where you could still find yourself in an inconclusive situation. And nevertheless, again, any genetic testing, especially in the pediatric population, has additional social, ethical, and also maybe legal implications. So it's a careful test that needs to be carefully evaluated and not being offered just like that. So what is the KDIGO 2025 guidelines? What do they support? They support or advocate a shared decision-making model. And, shared decision-making model in pediatrics is a well-accepted model. We use it for so many different, conditions. But all in all, what it means is that it puts needs to be a conversation between the physician and the parent or the guardian. And also there is a recommendation to include the mature child if possible. KDIGO doesn't say what a mature child would mean, but it would be different in some situations. But usually the age of 7 to 8 is like the age of ascent, and how kids can start participating. And again, it depends development-wise whether, so it would be very different in situation. But if the mature child can participate, then that would be the team who would be discussing that, whether to find or not to find, and then to discuss the screening strategies. And most of those screening strategies would be ultrasound and or genetic testing. And we said that negative imaging is not definitive at one point in time, and genetic testing can have additional implications. So all of that is a discussion. And then to find out, because then if you do a negative, and if you are negative for that genetic test of that for that familial variant, you definitely relieve that anxiety and you are ruling out a diagnosis. So that can be valuable to some families. And if you find out that you have a certain conditions, then you could have, more opportunities for registry participation, clinical trial participation. And then there is an opportunity for lifestyle changes, blood pressure management, which can sound very mundane, but I think it's like a very big opportunity piece that we have in pediatrics. But then there can be additional psychological burden. Sometimes the burden can be of that anxiety of not finding out. And some families may have a higher burden of just like finding out. and inconclusive testing, and depending on where you live, like what's your insurability based on your genetic testing. So all of those are things to be considered. So you can imagine this is a kind of a long discussion that needs to be happened, or an informed discussion. And I don't think there is enough guidance to the pediatricians in the country to have that kind of a discussion with all the families. And so depending on if the pediatrician is well equipped to have all these conversations, then I think pediatrician should be the first point of contact for the families to talk about this. And if the pediatrician doesn't have that kind of time or infrastructure or knowledge to talk about it, then I think one visit with the pediatric nephrologist to talk about all this is reasonable. Just to show that the KDIGO 2025 has this entire table about like what is the value of early screening and what are the possible complications of early screening. So there are definitely pros and cons that one can look at, but I think it should be an informed decision whether to test or not to test. And just a quick minute about what genetic testing, what role does genetic testing play in children with ADPKD? When is genetic testing indicated? Genetic testing is so easily available to all nephrologists and clinicians these days, and so there is, I think, it is very convenient to order a genetic test, but it needs to be carefully balanced as to like what is the provider expecting, what is the family expecting, so that there are no surprises in the end. And in general, in ADPKD, in children, when there is clinically probable ADPKD, we would typically, for sure do genetic testing if it's like a very severe presentation, very early presentation. So anything out of the ordinary that would be expected for that age-appropriate polycystic kidney disease, or if there is an absence of family history, because there are other causes of cystic kidney diseases or cystic kidney conditions in children. And then almost whenever we are suspecting ARPKD, we will always go and do genetic testing. And ideally, it's done with a genetic counseling session. So just, to say that we should not, that as pediatric nephrologists, we don't jump to genetic testing for all children with ADPKD. But overall, there is more and more move as we, as knowledge has evolved better, we feel more equipped to like talk about these things. And if we have genetic counseling at hand, we are trying to do more and more testing. Management of blood pressure, I think it's something that we talk in adults all the time, in specifically pediatric issues related to ADPKD, and how does blood pressure control factor into all of that. We know that when you have the more severe autosomal recessive kind of polycystic kidney disease, almost all of those kids will have systemic or hypertension or high blood pressure. And a good proportion of children with ADPKD will have high blood pressure. And blood pressure in general is an established but modifiable risk factor in CKD in children. We have studies not specifically in ADPKD in children, but other CKD cohorts in children that shows blood pressure as an established risk factor in CKD. And so I think it makes a lot of sense by evidence and by the pathophysiology that blood pressure needs to be controlled, even in kids with ADPKD. It needs to be picked up. It's something that you don't want to miss, and it should be managed in children with PKD, and also at children at risk for ADPKD who are not tested, so they don't know if they have PKD or not. But getting a good blood pressure, which, when you go to the pediatrician, making sure that a good blood pressure was done, maintaining a blood pressure log at home, so not to miss any higher blood pressure readings and not to lose that opportunity of the modifiable risk factor control. In terms of like what other symptoms and complications could arise in children with ADPKD who have normal kidney function throughout their childhood, we talked about the blood pressure. Then protein leak in the urine is something. There could be a medicine to control it. There could be lifestyle measures to control it. So that is something that is again linked to CKD progression, and so it is one of the other CKD progression delay opportunities with an early diagnosis or finding out early that you have ADPKD. And so testing both blood pressure and urine protein, irrespective of whether you found out or not, so in all children at risk, should definitely be something that is done, even if the family for not doing imaging or genetic testing early on. And so there is a lot of, a focus, I think, that we're reliant on education for all this. And, so a lot of information during provider interactions is needed. There are some other real complications that we do see even in the proportion of ADPKD that is quote unquote asymptomatic and was not like early presenting, so didn't present in neonatal or early infancy, but children with ADPKD who have normal kidney function are at higher risk for forming stones or urinary tract infections, and sometimes you do see those complications in the clinic. It's not very common to see the complications, but there are definitely kids who need that complication monitoring. And then large dominant cysts, so one of the kidney cysts on one side becoming so large that it needs surgical management. It's a rare complication, but these kind of situations we've handled in conjunction with urology, where the kid had like almost one of the cysts was as large as the kidney. And so that is something that to keep in mind, that it's not without complications. And what about the non-kidney manifestations? In adults, we talked a lot about the liver cysts being the most common non-kidney cysts that are present. And in children, non-kidney manifestations are practically non-existent. And so we do not routinely monitor for extrarenal complications in children because they are rare. They're anecdotal. There are case reports, but there isn't, but they're extremely rare. So unnecessary liver imaging is not needed, but what we will do is that because there are other differential diagnoses of having bilateral cysts in the kidneys, and some of those other differential diagnoses of having cyst in the kidney in children also go hand in hand sometimes with liver conditions, especially like having fibrosis or other cystic conditions in the liver. And so typically at evaluation, you would do like a one-time liver evaluation just to make sure that this is ADPKD and not other hepatorenal fibrocystic disorders. And but typically children will not manifest liver cysts. But it does become a consideration when kids are growing older and approaching 18 years of age, and especially in females, and if they are seeing OBGYN for another hormonal indication and are being prescribed certain agents, and then you want to talk with those providers to see that your liver cyst risk is not modified in any way. And then, talking about other extrarenal complications, I think aneurysm screening is talked about, and we in adults there are recommendations on the consensus statement as to how you should do the imaging based on what your risk is, and that risk is heavily dependent on if you have a family history of brain aneurysm in an ADPKD affected individual. In kids, this kind of a complication is practically very rare or non-existent. But if you look at case reports, there is a one-off case report that this happened, and there was an aneurysm. But again, I think it needs to be balanced out. And what I do in the clinic is, I without causing unnecessary anxiety around intracranial aneurysm in a population when most likely we will not see it, but also not to keep them uninformed. At least at one of the interactions you need to talk about that this is something that we need to watch out for in the future, so that you're providing information but also not causing unnecessary anxiety. And I think that interaction turns out to be more useful not only for the children but also the affected parent, because sometimes the parent hasn't had that kind of a conversation with their nephrologist, and then you can so when you're seeing children with ADPKD, it's actually an opportunity to counsel the entire family, talk to the entire family, and that is valuable. And then, you need to revisit such discussions of extrarenal complications when you're transitioning the patients. So when they are 18, so, the conversations are very different seeing a 3-year-old with ADPKD versus seeing who's an almost 18, because now your risks will be something that you'll be entering adulthood. So having those discussions around the transition of care, again, becomes important for the pediatric nephrologist. And, the guidelines also talk about the pediatric to adult transition of care models and what kind of care models, should be developed. And the PKD Foundation has come up or will be coming up with like transition of care document as well. And so there is an emphasis on a very seamless transition, because transition is the age when the kids are entering the adulthood, but that's also the age when they're going to college. And so, it becomes tricky for a PKD pediatric nephrologist to find, a suitable, geographically located PKD physician for a kid who will be leaving family, going to college, but is also now an adult. So, and the pediatric to adult transition of care needs to be more timely in AD-PKD than in some other maybe chronic kidney conditions, because your management and screening options and, they expand beyond 18 years of age. So it needs to be a very timely kind of a conversation to have. And I think what's been really nice is having these centers of excellence. So we have not only, the pediatric centers, but obviously we have like these, adult centers of excellence and in partner clinics. And so I think, the transition of care is much more streamlined since we have these centers and more information on what to do. This is my last slide, and I just wanted to, because, traditionally AD-PKD has been thought to be, this is something that is an adult disorder, and AR-PKD is like a pediatric PKD. And we know now that that's not the case. And I think we should tap into that opportunity window of seeing, when we see the kids early and, all the good diet or the lifestyle modifications and whatever we just heard about, like if they can happen early and they can happen, something that can be assimilated into like everybody's lifestyle early on, I think it will be an invaluable thing to do for our kids with AD-PKD. But even when we, as a pediatric nephrologist, when we see prenatal consults, when somebody's pregnant with a fetus and a woman with AD-PKD is pregnant with a fetus and the fetus has kidney cyst or some kind of a kidney abnormalities, that can be a very anxiety-provoking situation. But again, thinking about AD-PKD specifically and not AR-PKD, those are very two different conversations we have with women who say present at like 26 weeks, 28 weeks with fetus affected with a cyst with AD-PKD. Because even if you see mild radiographic abnormalities in the AD-PKD affected fetus with, cysts, it's because now we do more ultrasounds. Our techniques are much more sophisticated. We tend to find out about cysts. So mild radiographic abnormalities in the fetus, which are observed during routine follow-up during pregnancy, may not necessarily predict that the child is going to have a severe AD-PKD. And that conversation could be different in other syndromic cystic kidney conditions. So it really needs to be on the top of your, differential all the time, so that, you're not inadvertently just prognosticating in a more severe manner than you need to. And, when you have severely affected fetus with AD-PKD, then, there is low amniotic fluid. So it does portend a higher risk for a poor neonatal outcome, but we don't have that kind of a systematic data in AD-PKD. We have some in AR-PKD to say that, what kind of, that 1/3 of those kids would require dialysis in the first 3 years of life. But we don't have that kind of a systematic data for AD-PKD. So the conversations with those families who are at this crucial stage of deciding what to do in the pregnancy can be very, very, different. And obviously a normal fetal ultrasound does not rule out AD-PKD. So just, saying that, even though we do see AR-PKD, AD-PKD is always, more common and, something that we see all the time. This is one of the, flower and petal picture that was part of one of the ASN posters we did last year, prepared by Krista Wink from our clinical PKD team. And we actually looked at like our, the kids with AD-PKD, and we realized that these kids do have some multidisciplinary needs in terms of not only nephrology care or the complications of, which were more kidney related or blood pressure related, but also other CKD risk factors. Some of these kids were overweight, had obesity, or just had some, nutrition, the kids who could benefit from nutritional support And just like, HbA1c measurement or lipid measurement, just because of their weight management. And so making those kind of risk factor referrals to preventive cardiology department and having like a partnership. So that's what we've tried to do in our clinic, have a partnership with the preventive cardiology department so that we can have like a smooth co-management of these kids. And then, having partnership in urology, because, one for time, like you have a big cyst that needs to be taken care of. Psychosocial needs in these kids can be very different, and having somebody who they can talk to in the clinic when they're coming to see you because these kids are always, they are absorbing conversations about how an adult parent is affected by ADPKD, and they've probably known about their grandparents. So it's a very different kind of a CKD, a population than you would have like in a situation where there isn't a genetic component. And so, psychosocial needs can be different. And so there could be a need for multidisciplinary management. And I think the guidelines provide a valuable framework for management discussions in the pediatric kidney clinic. And, the PKD Foundation has these handbooks, and Paul just told me that there was the ARPKD handbook is out or soon to be out, and it's absolutely new, but I'm happy to take any questions.
Hi there, thank you so much for this talk. So before this started, I shared with you that I have 2 kids who are at risk for ADPKD, haven't been diagnosed formally yet. But I'm curious, before going through that process, just at-home care, like there was no mention of NSAIDs or anything like that. And I'm wondering if the same guidance that I'm getting basically to take care of myself, if that's just worthwhile to implement for my children. So avoiding NSAIDs, keeping salt low, keeping them super hydrated, et cetera.
So, as the blood pressure and the protein leak in the urine are the only 2 things that we don't want to miss, even if we're not checking the ultrasound or doing genetic testing. The other kind of general lifestyle measures and healthy, diet recommendations, I think, that we need to just, it's a good idea to adopt that. We just need to be careful that we're not kind of overdoing something that we don't need to do, especially with the protein intake. In children, we never, say that restrict protein intake because growth is paramount. And so some of those, diet recommendations might look different for kids than for adults. I think sodium, I don't think any nephrologist sees any good in like taking more sodium. So I don't see any positive side of like defending that. But so yes, most of those, and then avoiding NSAIDs but when you need to take NSAIDs, then how much you can take and how much with hydration, you can still take it, but like with good hydration, any other medications that are not kidney safe, so all these conversations. But I think, in general, those principles do apply.
Ashima, what do you tell parents whose kids are involved in like sports? Like, do you have any limitations that you advise in terms of?
So typically, we would do some ultrasound imaging intermittently and look at the kidney size. Just, an ultrasound-based assessment of the kidney size. And if the kidneys are large, or if there is like one of the cysts is dominant or any worrisome looking, then it would be a slight, but we would typically tell them to get like abdominal support or guard to and to avoid contact sports because of the large kidneys. Recommended blood pressure range is good for children with or at risk for ADPKD. For a child at risk, but has not been diagnosed. So blood pressure recommendations, we have in pediatrics, we have blood pressure recommendations based on the demographic parameters that include age, gender, and height. And then we calculate the centiles. And so depending on the gender, the age, and the height, you will have a different centile, and then what centile is good for that particular age. And typically for chronic kidney disease, the lower the blood pressure, the better it is thought. So if you push it below the 50th centile, there is data that CKD progression is delayed more than if you push it below the 75th centile. So anything more than 95th centile is definitely hypertension. So you would imagine that even like having in chronic kidney disease, typically we would want to push it absolutely below the 90th centile. But there's data if you push it further down, So you can imagine between the 90th and the 50th centile, like pushing the blood pressure, it would mean higher doses of medication, more medications, and that sometimes is practically impossible to achieve in kids, especially when they're up and about and like going to school. And so to strike a middle ground, there is also some data that, you push towards the 75th centile. And that's typically what we do in clinic. So you don't go by just you're not satisfied just like by below the 90th centile, but cannot go below the 50th. So you would just target for somewhere below the 75th centile, but that number could change depending on the age. The tricky part is that the American Academy of Pediatrics flowcharts that we have about like what blood pressure at what centile only gives us the 50th and doesn't give us the 75th. So it's a little bit of calculation, but that's what we typically do in the clinic. And then do you recommend avoidance of NSAIDs? Yes, I think avoidance I do recommend. I cannot say that it's an absolute contraindication. We have situations where a kid with ADPKD gets admitted with appendicitis and, so we do, in a controlled way, but we always kind of sit on the head of people and say that, just do as little as possible. But I think hydration is the key with NSAIDs. All right, thank you.
All right, thank you so much, everybody, for attending. We have concluded our 4 expert talks. We are still going to do our breakout sessions. I realize we are a little bit behind time, which is great. We had great presentations and great questions, so I'm not unhappy about that. I think we need to give a few minute break, so I would like to still give a 10-minute break, or we'll go. At 1:05, we will start our breakout sessions. How's that? So that gives everyone some time to use the bathroom, grab a snack, drink. And then for those on Zoom, please log in to the Zoom of your choice. And then our hosts here will be, I think each one has an in-person and then a virtual host. So we've got 3 sessions. We have participating in the clinical trial, where that's going to be in person. We have Greg, he is our patient participant who's going to talk about his experience participating in clinical trials. And then Charlotte Diggs, she's our research nurse. She will be on the virtual side of that, kind of talking about clinical trials as well. So if you have any questions, you've never participated, you want to learn more information, it's a great session to join. We have Living with PKD, Dr. Terry Watnick, and a patient who has post-transplant, so has kind of lived the pre and post. He's going to be part of that session and is going to be able to talk from their perspective about their experience living with PKD. If you have just general questions that didn't get answered, could be a good breakout session for you. And then our last topic is pediatric PKD, just to talk a little bit more, Dr. Gulati, if you have further questions that you didn't get answered in the chat, that would be our last session. So we will reconvene at 1:05 in those 3 sessions. And thank you so much for joining. Take care.